Namaskar दोस्तों. I'm Purnima from Fertility Dost and let's start another session. Yes, today we are going to talk about IVF related myths. बहुत बार हमने सुना, बहुत बार हमने सोचा भी कि IVF फेल हुआ. My cycle is failed. What could be the reason for this? Is this because of my egg quality, or is this because of his sperm quality, or is this because of my uterus condition, my stress levels, my eating habits, what all? So today we'll discuss that what could be the factors that will be the deciding factors for your success of the cycle, or we can say that failure. And again, there are many myths related to this. One interesting myth is that someone asked me that during this embryo transfer period, uh, should I wash my hair? So I think this is interesting myth. We'll talk about lot more. We'll discuss lot more. And if you have any queries, if you have any doubts, if you have any inner thoughts that you thought that, oh God, I need to discuss with my doctor, but I forgot. So just post here on the comment section. And if you want your query to be posted as anonymous, then please send us a message on our official number. We'll be posting it as anonymously, and I request you to please stay here in the session till end, बिकॉज हम शुरू से लेके एंड तक बहुत इंटरेस्टिंग चीज़ें, बहुत इंटरेस्टिंग बातें डिस्कस करने वाले हैं. बिकॉज आज का हमारा जो टॉपिक है, दिस इज बर्स्टिंग द मिथ्स रिलेटेड टू IVF. चाहे वो फेलियर है, चाहे वो सक्सेस है, बिकॉज वी रियली वॉन्ट यू to achieve your goal of parenthood. And I'll add my guest doctor today on the main screen, and then we'll start the session. And once again, thank you UNS for arranging such informative sessions. UNS हमारे informative partners हैं. ये हमेशा हम कहें इंडिया के कोने कोने से टॉप स्पेशलिस्ट, टॉप फर्टिलिटी स्पेशलिस्ट को हमारे प्लेटफॉर्म पे लेके आते हैं. थैंक यू सो मच फॉर स्प्रेडिंग द अवेयरनेस with fertility those. Thank you UNS. And viewers, let's have Dr. Sweta with us and let's start the session. Namaskar, good evening Dr. Sweta.
Hello Purnima.
So viewers, today we have Dr. Sweta with us. As discussed, we have very important topic, and to tell you more, this session is live on our Facebook page, Facebook group, and on our YouTube channel also. तो अगर आप कहीं पे भी हैं, आपको लग रहा है you are not able to access the Facebook, then please move towards the YouTube. There also we are live at this time. So today with Dr. Sweta, we are going to discuss about the bursting the myths around IVF. And Dr. Sweta is a director of Southern Gem Hospital, Hyderabad. So viewers, Hyderabad or Sikandrabad or nearby places, if you have any concerns, any issues related to fertility, please don't hesitate to visit Dr. Sweta. She has masters in reproductive endocrinologist and infertility. And interestingly, she has treated n number of cases related to each and every problem, whether it is male infertility, female infertility, whether the things related to freezing, embryos, each and everything. She has dealt many cases in the past, and we assume that you are also going to help with her knowledge. And Dr. Sweta has more than 20 years of experience. And to tell you about more about the Southern Gem Hospital, this hospital has been named as second best fertility center in South India and 10th best in North India. So don't worry about the facilities, don't worry about the specialists, don't worry about the lab conditions. Dr. Sweta, let's start with the session and let's start with the main topic. So, bursting the myths around IVF. Please, ma'am.
Yes, yeah, definitely Purnima.
So, first of all, ma'am, we have seen many cases where the people are concerned about these small myths. Sometimes these are related to gametes conditions. Sometimes these are related to uterus conditions. In your this we can say that 20 years of practice, 20 years of experience, what kind of myths, what kind of things you encountered that you really want to discuss with our viewers?
See, whenever we talk about a patient, coming with the failed IVF, we always say that the reason could for a failed IVF could be as either in the gametes, like either the egg quality is poor. We know the embryo which is made, which is a combination of egg and the sperm together. So if there is a problem in the gamete quality, be it the egg or the sperm, so we are going to get a poor quality embryo, and that is the reason for a failed IVF. And again, the second reason could be the uterine factors, the factors related to the uterus. We make the embryo, we make it ready outside the uterus, and then put it inside the uterus. So, quite often, there could be some factors which are related to the uterus, like the presence of any polyps or fibroids in the uterus, or it could be any septum inside the uterus or adhesions inside the uterus. So, any of these uterine factors could be the reason. Other factors are the female, the ladies, the blood could be having a higher clotting factors, like they could be antiphospholipid antibody syndrome, where there are certain factors in the blood which makes it more thicker, which has an impact on the implantation of the embryo, and it reduces the chances of implantation, and also it increases the risk of miscarriage in such women. So most these are the most common reason, I want the gametes or the uterus or the blood clotting factor conditions. And sometimes it could be unexplainable. It could be just bad luck, we think sometimes, because there are so many factors in infertility which we don't have an answer for as well. So these are the most common. So whenever somebody comes with this failed IVF, we tend to evaluate in these lines.
Dr. Shweta, I think we tend to evaluate, or we can say that we usually many tests are related to evaluate the female condition,
Yeah.
but for male, it's a simple one test. So let's start with the male factors today, and then we'll shift our focus to female, because usually we start the session with female and then
Mm.
shift towards male. So
Okay.
let's talk about males first.
Yeah.
So simple semen analysis, we all know. But nowadays, many other factors are just cropping up. So could you please explain the few factors, like many people are nowadays have this concern about morphological conditions. The next they discuss is what about DFIs. So please some light on these two things.
Okay. Yeah, sure. See, the embryo is a combination of both egg and the sperm. So both of them, both the egg and the sperm, are contributing equally to the embryo quality. So if the sperm quality is not good, eventually the embryo quality is not going to be good as well. So in the males, we know it's very simple and easy. We do the semen analysis, and in the in the semen analysis, we look at three things. One is the sperm count, then the sperm motility, and then the sperm morphology. So these are the three factors which we most commonly look at in the sperm. So if there is poor motility or poor sperm morphology, again, the quality of the sperm, if it is not good, it has an impact. And then the other thing what we like to check for in patients with failed IVFs or the patients with repeated miscarriages is the sperm DFI, the DNA fragmentation of the sperm. So in the head of the sperm is the DNA, and then we look at the to what extent is the DNA fragmented. The higher the fragmentation level of the DNA, the poorer is the sperm quality, and that is going to give us a poor chances of pregnancy, or there's an increased chance of miscarriages in these cases of people. So with these patients where there is a poor sperm quality with the different sperm parameters, or if the DFI is high, we put the patients on antioxidant therapy. We put them on antioxidant therapy for 2 to 3 months before IVF to improve the sperm quality. And sometimes, if the patient has very high DFI, recently, in more recent times, As we know, that the husband produces a semen sample, and we use the semen sample to do the IVF or the ICSI. But when the DFI is very high, we tend to take the sperm directly from the testis. So we do testicular sperm aspiration directly, where the production of the sperm happens in the testis. What is said that as the sperm passes through the tube to the outside, there might be some conditions which may damage the sperm and make the DFI high. So if we directly collect the sperm from the testis, the DFI of such sperm collected from the testis is lower, and that could give us a better chances of pregnancy. So we tend to collect the testicular sperm, we aspirate the sperm from the testis and use this sperm for the IVF or ICSI treatment. So men with high DFI, this is something which we can do. And also we go back into the history of the patient. We ask if the husband is smoking, or is he using some recreational drugs or alcohol. All of this history is also very important. So smoking tends to damage the sperm. It's going to affect the various sperm parameters and cause high sperm damage, and DFI is high. So we recommend the men to stop smoking, reduce the alcohol, stop recreational drugs. We also, if the obese men, we recommend that they need to lose some weight to improve the sperm quality. So the history is also very important, and the occupation of the man is also important. If he's working in heated environment, in the hot furnaces, if they are getting exposed to high temperatures, as we know, the testis is placed outside the body in the scrotum, because the sperm production and to maintain the sperm quality, it needs a little bit lower temperature than the normal body temperature. So when the person is working, when the man is working in environments where there is high temperatures, such as in mines or in hot furnaces, getting exposed to these temperatures, sometimes the sperm quality is affected. So looking at all of these factors, it's important to take the history of the patient, the working environment, his habits, his weight. All of these needs to be looked at. And also, once we find all of these problems, if we can address with the antioxidant therapy, that will be great. But sometimes we need to collect the sperm from the testis to make the chances of pregnancy better.
Dr. Shweta, if we talk about this thing, treatment and all, so usually people say is that 3 month of treatment is enough for male factor. Is it really so?
See, no, see, when it comes to the male factor fertility, everything is not under our control. We cannot say that giving this antioxidant therapy, everything is going to get corrected. Even if they take it for a few months, they, the sperm parameters are going to go back to normal. No, there is so much about male fertility which we don't know. So it's very important to explain that to the patient as well. We can give them a few months of antioxidant therapy, and there's not 100% chance that the man is going to respond to it. So there's some men may respond and some may not respond at all.
Okay, right. So we can say that discussing things with your doctor and taking treatment is the best option for.
Yeah, it's always better to discuss your doubts, whatever you have, your queries with the doctor, and understand and accept the treatment what is available. Because what happens in so many times in fertility, there are so many factors which we don't know what could be the underlying cause, particularly in the male. We don't know many times the underlying factor, and a number of treatments which we give to men are empirical, which means with empirical we mean that these treatment may work or may not work, but at least they are not harmful, they do not have negative side effects. So they may be useful, they may not be useful, but because they are not going to have a negative impact, we tend to give them to them.
Right. Uh, Dr. Shweta, usually when we discuss about male factors, so it's just that age has no effect on male infertility. And we all know that, yes, it happens. But what about the hormonal conditions? Because for female, we have n number of hormone tests. We usually start with AMH, FSH, LH, thyroid, prolactin. What about the male parameters? Do we really have certain set of hormonal tests for male also?
So with the when it comes to the male factor, with the men, see, if the semen count is normal, if the semen analysis is normal, then we don't tend to do any kind of hormone test for the male. But if there is a problem with the sperm count or motility or morphology, if there are issues with the sperm, or if the man is azoospermic, if there is no sperm in the semen, in such men, we tend to do the certain hormone tests like the FSH, the LH, the testosterone, the male hormone levels. These tests we tend to do for them. And sometimes there could be an underlying genetic factor, with the with the men, there could be an underlying genetic reason why they are azoospermic, or with azoospermic it means there is no sperm in the semen. So why are they azoospermic? Why do they have a very low count, particularly if the count is less than 5 million? The normal count is more than 15 million, but if the count is less than 5 million, we tend to even rule out certain underlying genetic factors. With the underlying genetic factors, we tend to check for the male karyotype, or the genetic test for the male. We look for the microdeletions of Y chromosome, and we also look for cystic fibrosis gene mutation. So these three genetic tests are recommended for the male if they are less than 5 million sperm count or azoospermic men. And apart from this, a few hormone tests of FSH, LH, the thyroid function test, and the testosterone levels.
Right, understood. So we can say that yes, males at times do need some important
Yes,
investigation.
yes. Only when if they are having low sperm count and all, definitely we
Hmm.
need to do this hormone test to understand where what at what level is the problem, and accordingly we can give treatment to improve the count and other parameters.
Right. So, Dr. Shweta, here we'll take one query.
Yeah, sure.
I had done ICSI with frozen semen sample on Feb 5th. Eggs retrieved, they looked good, but the
5x.
fertilization never happened. On day one itself, the eggs had never started to fertilize. Doctor told me as initial fertilization failure. AMH is 1.89, age 31. Confused how to proceed, don't want donor egg.
Okay. So see here, the patient had her AMH is borderline, like normally we say 2 to 6 is the normal range of AMH. 1.89 is low. She is 31-year-old, so okay, women, the fertility of the female starts to drop down a little bit after 30. So for her age, 1.8 is little bit on the lower side of AMH. And then she got only 5 eggs retrieved,
Mhm.
which looked good, and fertilization never happened. So if there was a fail, they already had. If she had IVF, I would recommend ICSI for her, but she had ICSI. So generally, the fertilization rates with ICSI are better than that with the IVF. And here, the husband's sperm sample was frozen. So how was the sperm counting? How was the semen analysis?
Right, right. If
So we
you
would
are in
like
the
to know something about the semen. Of course, she had 5 eggs. She had low egg count, so that could
same.
be one of the reason. But there could be a male factor as well. So we don't know how is the semen analysis, and why did we freeze the sperm? Was it a sperm which was retrieved? Sperm retrieval was done, or if the
Mhm.
husband had a low sperm count, what kind of sperm analysis was there?
Right. And Dr. Shweta, is it possible that frozen and fresh samples has some effect? Like we can say that no, fresh is better than frozen. Anything
This
like
is
this?
farm, see, frozen and fresh nowadays. We are using very good techniques for freezing called as vitrification. In the past, like in the past 15 years ago, 15 20 years ago, we had vitrification technique. We had slow freezing technique where the survival was little bit lesser. But nowadays with the vitrification technique, the survival of sperm or egg or the embryo, all of them are very good. So we are having about almost 100% survival of the gametes and the embryos with the vitrification. So it's equally good, whether you do a fresh sample or a frozen. There's no difference in the success rate, I would say.
Right, because nowadays, if we can see that we are doing frozen embryo transfer, maximum, I can say that 90% of cases are FET only.
No, see, in our center, what we do is we do both fresh and frozen. We don't just do frozen embryo transfer for all. We have a policy of both fresh and frozen transfers. It all depends on the how the embryos look like, how many embryos we get, and then on the day of the trigger, we tend to do the progesterone levels. So if the progesterone levels are less than 1, then the endometrium and the quality is reasonably okay, and we tend to go for fresh transfers as well, and we see good results with fresh transfers. So I would say we have 50-50 fresh and frozen transfers in our center.
So, Dr. Shweta, how you differentiate that? Yes, this is the candidate for fresh, and this is the frozen. Obviously, you just mentioned about the progesterone level and all that.
Yeah.
Any other factors that you consider?
Yeah, see, if we collect too many eggs, so one factor we look into it is the progesterone levels, which we do on the day of the trigger. And if they look good, then we give the patient an option of fresh transfer. Secondly, it depends upon the number of eggs. If we get too many eggs, if we get more than 15 to 20 eggs, the women is at a higher risk of ovarian hyperstimulation syndrome. So already she is at a higher risk of OHSS. So if we transfer the embryos in a fresh cycle, and if she conceives, her risk of OHSS is going to be very high. So in that case, we prefer to freeze the embryos and transfer in the next cycle. So these are the two most common indications where we tend to freeze the embryos.
Right.
Otherwise, we prefer to
And
go for pressure transfer.
okay. And many a times we have this kind of doubt, or we can say that myth, that if we are going to have maximum, or we can say that more number of IVF cycles, it could be the reason for cancer. Is it really true?
No, not at all. Not at all. Any kind of fertility treatments, be it simple stimulation for natural time relationships, or IUI, or IVF, whatever kind of fertility treatments, it's definitely proven that any kind of these fertility treatments do not increase your risk of cancer, ovarian cancer. Not at all.
Right. So we can say that if you are thinking about this, that yes, if you exceed the limit of the cycles, or if you have more number of IVF cycles, that it will going to impact your reproductive system or any kind of
No, it would not.
cancer, or so it's not possible,
Because
right?
these are very simple treatments, and the hormones and all, we are very close to what is normally produced in our system. So
Right. So Dr. Shweta, we'll take another query. My husband through all the test, micro deletion and chromosome test, as well as TSA and micro TSA as well, but no sperm found. What's the reason?
So it is not possible every time to find out the reason why there was no sperm. So if there is, suppose if we find microdeletion of Y chromosome or any karyotypic abnormality, then that could be the reason. But many times this can be Sertoli cell only syndrome. That means there is a germ cell factor. There's not enough germ cells in the testis, so then they tend to have no sperm production, and no sperm. So quite often when we do TISA and we don't find sperm, or micro TISA, we tend to find the sperm. The success of finding sperm with micro TISA is usually very good. But there could be possibly there. It is said that there could be some focal areas. There might be production of sperm in some focal areas in the testis and not throughout the testicular tissue. So in those cases, micro TSA is helpful, but the patient might be having just Sertoli cell only condition where there may not be any sperms, germ cells which are producing the sperm. So microdeletion is negative. There could be other factors in the karyotype can be done in this male. We don't have the karyotype report, but it is possible that even if the karyotype is normal and microdeletion of Y chromosome is negative, there could be no sperm production in this men, and
Okay.
it's
And
unexplained.
right. And what could be the solution? Only donor option is there?
Yeah, that's the only option they are left with. Even after TCA and micro TCA, if we do not find any sperm, then definitely the only option which this couple is left with is the donor sperm
Right.
or
Uh,
adoption.
right. So you can check with your doctor, and as Dr. Shweta just mentioned, that donor cycle or the adoption will be the option for you. Please look into these options, and if you really want to know more about uh, these procedures, more about these things process, then please let us know. You can message on our official number, and we'll directly connect you with the Dr. Shweta. And yes, if you want to go ahead with the adoption process, then also you can connect us. I'm a certified adoption counselor also, and I'll definitely going to help you in this. So Dr. Shweta, let's shift the focus towards female. So female, we have n number of tests. We know that hormones का test तो कराना ही है. And what about the condition of uterus? Nowadays we are having few common things like whenever we are discussing the uterus condition, the very common is septum. So how this
Yeah.
septum is going to affect the pregnancy or fertility rate for the woman?
Septum definitely, septum is of at different levels. So actually, how what is septum is usually uterus. When the girl is in her mother's tummy, at that time the uterine development is in two parts which comes together, and in the midline the septum gets dissolved and it forms a single uterine cavity. So sometimes it may not get dissolved, so it can be completely, it is not dissolved, so she may have a complete septum. Or if there is a partially, it is not resolved, then the patient tend to have a smaller partial septum, a smaller septum. So either she can have a complete septum or a partial septum can be there. So whenever the patient has a septum, it has an impact on her fertility. She's going to have an increase, lesser chances of conception. Sometimes even in the presence of a septum, the patient can get pregnant, but there is a higher risk of miscarriages, higher risk of premature delivery at fifth month, or at seventh month, and also the patient tends to have an increased chances of miscarriages and premature deliveries also. So definitely septum is something which we need to address in this group of patients.
So, could there be any solution for this, that after a surgery or something, the lady will be able to?
Yeah, definitely. We need to resect or cut this septum, the which is a very very simple procedure which we routinely do in our center. It's a very commonly done procedure which is called as a hysteroscopy. So for the hysteroscopy, the patient doesn't have any cuts on her tummy or anything. It is done simple procedure done under a simple general anesthesia. Takes about 10 to 15 minutes. It is done as a day surgery, which means the patient gets admitted in the morning. She has general anesthesia. We put a camera inside her uterus from below, vaginally through the mouth of the cervix. We put a camera inside her uterus and cut this septum, which is like a 10-minute procedure. After that, the patient comes out of anesthesia. She stays in the hospital for a few hours and goes home same day evening. And because she doesn't have any cuts on her tummy, she's okay to move around and mobilize on the same day, and next day she's back to work and normal activities. So it's a very very simple procedure which is done in our center as a day surgery procedure. And the beauty of this is, after correcting the septum, there is a very 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 good chance of conception. And once the septum is corrected, there is a natural conception chances also are very good. and the success of any kind of fertility treatment is also very good after a septal resection. So it's very important that if there is a septum, they need to correct it before your next cycle of IVF to maximize the success. And as I said, it's
Right.
a very simple and easy procedure, which is done very routinely in our center.
So we can say that if the condition is there, then please connect
You
with your
correct it.
doctor
Yeah,
as
yeah,
early as possible, right?
definitely.
And Dr. Shweta, you just mentioned that after the removal of this septum, even natural conception is possible.
Yeah.
So after this removal procedure, how many months gap should be there
No, see,
for planning?
suppose a patient is going for IVF. This
Hmm.
month, if we correct the septum, she can immediately go for IVF in her subsequent menstrual cycle, subsequent period.
Okay.
Immediately this month, if we do, normally we tend to do the septal correction immediately after the period from this between the 7th to 15th day of the cycle. We tend to do the septal correction. So this month, if we do the septal correction, next month when she gets her period, she can plan for treatment in that month itself.
Okay, that's great. That's great.
So there's no
So
waiting time.
right, and we can say that we are not wasting time when we are doing the corrective surgery.
Yeah, yeah, yeah. Only the month where you're treating is you don't do a treatment, but subsequent month onwards, they can straight away go for fertility treatments.
Right. Dr. Shweta, we have nowadays, we are seeing that many ladies are dealing with, we can say that low AMH, and doctors are advising them embryo pooling. And the very common query is this, that is this successive stimulation cycle, are they going to cause any harm to me? Are they going to deplete my ovaries from follicles, like after few years, or say 6 or 7 months? Some ladies are even asking that after 5 to 6 months, is it possible that my ovaries don't have even a single follicle left?
See, already the AMH is low. So that
Hmm.
means this woman is going to, as you know, the egg count as it's going to go down, or the follicle count if it is going to go down, she is going to go through menopause where the eggs are completely depleted. So somebody with a low AMH, she is going to go through depletion. The process of depletion of the eggs is going to happen every month. Every month we are making follicles, which are, whether you get pregnant or not, the follicles are going to be finishing every month. Every month some follicles are starting to grow, and then they are going to be depleted every month. So whether you are going to go for trying for a pregnancy or not, the depletion is going to happen. By going through the stimulation and egg collection, we are just collecting the eggs which are going to be lost in that month. You know
Right.
what I mean?
And
So this month, certain follicles are going to grow. They are going to form an egg, and then if you don't get pregnant, that egg is going to get wasted in that month. So if we are going to collect the eggs which are growing in this month, we are going to collect those eggs which are likely to deplete. So by going through repeated stimulation process, we are not going to deplete the eggs early. It's just we are collecting the ones which are going to be lost in this particular month. So it's not going to have an impact on your depletion process of the eggs by going for repeated collection cycle. In fact, by going for follicular pooling, we are collecting the eggs from every month. We are getting a
hmm,
pool of follicles, or the pool of embryos, and we are going to pick up the best embryos from this and transfer into the uterus of the women to give her a maximum success rate in her first cycle itself of embryo transfer. So embryo
right.
pooling helps in selection of better embryos and better success rate for the woman.
Understood. So, if you have low AMH, or doctor suggested for embryo pooling, so as per Dr. Shweta, please go ahead. Don't
Yeah,
waste
that's a
your
good
time.
option. That's definitely a good option.
And Dr. Shweta, how many cycles of stimulation generally we can say that we need to do for such ladies?
See, usually with low MH, by maybe doing 1 to 2, like 2 cycles or 3. Usually, I tend to do with this embryo pooling at least 2 cycles, not one. We will get 3 to 4 embryos in this cycle, a couple of embryos in another cycle. So if we have a pool of 3, 4 embryos, we can pick up the best ones from this and put back to the uterus. So 2 cycles or 3 max in this pooling.
Three.
Two
And
to
this could be done like on successive months, or we
successive
really need
cycles,
to.
successive cycles,
Oh,
yeah.
okay, okay. So there's no need to give a month break before starting the new
No,
cycle.
we tend to do back to back these cycles because already we are going to collect embryos of this cycle and the next cycle and transfer.
Hmm.
So it's a process of 2 to 3 months by itself. And if you're going to give breaks in between, it's going to lengthen the process of treatment.
Right, right. Understood, understood. Dr. Shweta, we'll take another query over
Yeah.
here. My doctor transferred embryo of 10A with embryo of 6A grade to maximize implantation, but result was negative. What's the reason for failed implantation? Poor quality embryo interfered it.
See, I don't know whether with that embryo I would like to know whether it was a blastocyst or a day 3 embryo. With the blastocyst, the implantation rates are better. So the blastocyst, what we tend to do in our center is we try to take most of our embryos to day 5 or a blastocyst and transfer. So with the blastocyst transfer, we always get a better success rate. And if her implantation has failed, it can be either a poorer embryo quality, or then we also need to understand the uterine factor as well. So we don't have your information regarding the uterine factor. Did she have a hysteroscopy and the uterine factor was taken care of? And if it is an embryo factor, we tend to recommend that if there is an embryo related issues, in the next cycle we can do embryo pooling and do a pre-implantation genetic testing, PGT. So we take an
Hmm.
embryo biopsy and check the embryos for the embryo quality or the aneuploidy. If the embryos are normal genetically or abnormal, we can look at that. So somebody with 2 or 3 failed IVF, we recommend pre-implantation genetic testing for the embryo too, because sometimes the embryo may look good.
Good.
With look good, I mean when we do the embryo grading, the embryologist will say that the grading of the embryo is looking good. This embryo is something which we could transfer. But when we do the embryo biopsy and look at the pre-implantation genetic testing, some of the embryos which look good according to the embryologist, based on the grading of the number of cells and all, if they look good, but when you take the biopsy, they may not be euploid or genetically normal embryos. So such embryos, if we transfer, the patient may not have success rate. So somebody with 2 or more failed IVF, we tend to recommend to them pre-implantation genetic tests as well.
Right. And if you are in the session, you can please post the query containing the further information. As Dr. Shweta just mentioned, that we really need to know whether the embryos is of day 3 or day 5. We'll take another one. Just right. Is it good to go for IVF with 1.2 AMH level, or donor egg is the only option?
See, somebody with an AMH of 1.2, I would say that you can go for your own eggs. I have patients with AMH of zero point 0.2 and even zero point 0.5 who have done embryo pooling with us with 1 to 2 cycles of stimulation, and they have child which are genetically related. So for any women, any woman would like to have a child with her own eggs, a child which is genetically related to you. So with an AMH of 1.2, I would not recommend to my patient to go for a donor egg. Even I said, I always, with any level of AMH, be it, I said, I have a patient with zero point 0.2 AMH also, who got pregnant and had a baby delivered. She's got live child. So always with any women with such AMH levels also, we give them an option that whether she wants to go for her own eggs. It's nothing wrong in trying a cycle with your own eggs. You might be lucky that you will get pregnant. And if you do not get pregnant in your first cycle with your own eggs, you understand better where is the fault. Is it the egg quality or the sperm factor or the uterine factor? And after, if you suppose you're lucky, you get pregnant, nothing like it. But if you're not pregnant with the first cycle, you can go for a donor in your subsequent cycle. But you need to give yourself a fair chance. If you desire to have a child which is genetically related, I've got a number of patients with with AMH of 1.2 who have genetically related children. So with the AMH of 1.2, I would definitely say that you can go for your own cycle at least
Right.
once.
Once. Understood. And as Dr. Shweta mentioned, we also have many members who conceive with low AMH values. We can say that less than one also. Usually, Dr. Shweta, we all know that day five embryos are better quality embryos uh, if we compare them with day three. But as a doctor, what your suggestion is?
You see, always we tend to try to take in our center, we've got a very excellent lab, and we've got some equipments like in the lab, which are very good for culturing the embryos to day five. We tend to take most of our embryos to day five, unless until we have very less number of embryos. If we have 3 or 4 embryos, these are the embryos which we are going to put back into the uterus, so we put it back on day 3. But if we have anything more than 4 or 5 embryos, we tend to take them to day 5, so that we have a better embryo selection. So if we have, say, 5 embryos, we are going to put back 1 or 2 embryos and freeze the remaining embryos. And by chance, if these are the embryos which may not be able to make it to day 5, it's going to be an unnecessary transfer for these women. So if
Right.
we take these
Right.
5 embryos to day 5, we may have 1 or 2 day 5 embryos with us. So we may put back one and freeze the second embryo. So it's a natural process of selection where we can do a better embryo selection, so that we are not having unnecessary transfers.
Right. Understood. And what is the stage when you suggest your patients to go ahead with genetic screening of embryo?
2 or more failed IVF is one reason
Hmm.
where we do PGT-A or pre-implantation genetic testing for the embryos. And second reason for genetic testing is if the couple has an underlying genetic condition, or if they have a child which is genetically abnormal. So, for example, if there is a in the family there is a child with thalassemia. Thalassemia is very common in our Southeast Asian population. So if they have a child with thalassemia, or any other, or sometimes there is we have done for children with patients who have Duchenne muscular dystrophy, some kind of genetic conditions. If there is an underlying genetic condition in the family, then we recommend pre-implantation genetic testing for this couple, or otherwise for somebody with 2 or more failed IVF,
Right. And Dr. Shweta, what could be the
or somebody with an
gap
advanced
between
stage, 35 or more, if they,
age?
you know,
Right. Right.
advanced aged.
And hmm. Uh, but obviously, we should have good number of embryos
Yeah,
with
we need
us.
to have good number of embryos, at least 4 or 5 embryos, at least 5 embryos, of day 5. If we
Hmm.
have, then it is always better, at that, because if we have 4 to 5 embryos, 1 or 2 may be abnormal, 1 or 2 may be normal. So we'll have some embryos to transfer. So if we have only 1 or 2 embryos, in that case, we can go for 2 cycles of stimulation, get reasonable number of embryos for biopsy, so that the patient is not disappointed.
Right.
We'll have
Right.
something to transfer for this couple.
Right. Right. Because we all know that this journey is a real
It's a very
tough
tough,
journey.
yeah, and it's a very difficult journey. It involves lots of money, and and lot of emotions. Everything is there associated with it. So at the end of the day, we want to put back some good embryos and give a positive results for our patients. We're always working for that.
Right. Right. And it is really important for doctor as well as the patient. Positive
We
result.
both have to be positive and satisfied.
Right, right. So, Dr. Shweta, we discussed about egg pooling, embryo pooling. So, and what about, and during that thing you just mentioned that there's no need to have a gap between two stimulation cycles.
Yeah.
But what about the embryo transfer cycles? If one failed, then how much gap should be there for second ET?
We can go for the same subsequent cycle. Even back to back embryo
Mhm.
transfer cycles can be done. They don't have to be a gap medically, as long as patient is comfortable or not. Sometimes, when they go for an embryo transfer, the patient may be emotionally not very comfortable to go immediately for the next cycle. She may like, she would have had medications for a couple of months, and they tell that, I want to have a break of a month of medication before I go for my next cycle. So in
Hmm.
those, by like for patient related reasons, emotionally or physically, she might not be feeling very, comfortable, that she wants a break, then we give a break. But medically, we can go for back to back frozen cycles. There's no need of a break.
Okay, right, right. So we can say that while when we are undergoing stimulation or for frozen embryo transfer, if required, you can take break, but medically, doctors
We
say
can go
that
for back to back. Yeah,
back to back.
definitely.
Right, understood. So, Dr. Shweta, I think we covered the queries and we have very good discussion, and even I think these are the very small pointers, but yes, again, it's really nice to hear something with the known doctor, and it's really nice to know more because we have first hand experience with Google. We can say that coming from a specialist is something different because it has its own reasoning and facts attached to this.
That's true. That's true. That was really nice of you, Poonam. Very good questions, I would say. You have put it across, which are very, very practical questions, which we take it every day from our patients. They're always, with fertility, there are so many doubts, so many queries, which are always there. And there are very simple questions, but they have, as you said, it gives a lot of satisfaction to the patients when these queries are sorted out. So yes, there are always lots of myths around IVF, but these are very good treatments, I would say. Maybe if you look at 25, 30 years ago, where IVF first baby was like 45 years ago, 45, 46 years ago. So before that, there was no IVF. And in our country, we are having this around in the last 30 years, we are seeing all of these treatments. So definitely, there are lots of queries, lots of myths, but the acceptability of this treatment is much, much more than what it used to be before. And people are quite open about their problems with fertility. They are coming forward with this treatment. Acceptance of IVF is much better. And these are very simple treatments. They don't have any long term side effects for the patient. And the success of IVF is getting better every year, I would say. We are
Right.
having much, much better treatment. Our success of treatment is getting better. We have got better medications. We have got better lab facilities. We have got more trained doctors and more experienced doctors now. So I would say that if you need to go for IVF for a particular reason, the patient shouldn't hold themselves back. They should go
Hmm.
for it, because the success of fertility treatment or success of IVF depends on the age of the woman. That is a very prime factor. And when you know that you need IVF, don't delay it for another year or so, because in another
Right.
year, your success of IVF is going to come down, because you're going to be 1 year more older. Your eggs are going to be 1 more year older, and your success is going to be a little bit less than what it is today after 1 year. So when you know that you need to go for IVF, when there is a definite reason, clear cut indication in front of you, you've got blocked tube, husband's sperm count is so low, your egg
Hmm.
counting is low, when you know you will have to go for IVF, I would say please don't delay it thinking that it would happen naturally by itself. So that's one message I want to put it across to all the viewers, that when you know that you need IVF, don't postpone it, because the success is completely dependent on the age of the women. We as IVF specialists, we are just putting the gametes together and putting it back into the uterus. Okay, so we are not doing any magic or anything. So it's just the success is on the quality of the gametes. We are just handling it in a better way outside and putting it back into the uterus. So at the end of the day, we are not doing any miracle or anything. It's with just handling the gamete in a better way is what we are doing outside the body, which would happen naturally in their own system because of low count of the sperm or because of the blockade of the tube. These are more common reasons, why it is not happening. So we are just putting them together, which would happen naturally in your system. And ultimately the success of IVF is on the quality of their gametes, which we are just
Yes.
handling outside. So when you know that you need IVF, go for it. Don't delay it. Is the only message I would put it across to the patients.
Right. And this is really very important message because it's like, I don't know, it's a mindset or what we always think, koi baat nahi. Let's see next month.
Yeah,
Let's see
next
next.
month, and next month is like next year. I see, so many patients, they come and consult me today and they come back a year later. So I tell them, 1 year later your success is going to be a little bit lesser than whatever it was last year, and by now she would have been with a live child in her hands, maybe in her arms. So that's very important, for the patients to understand that it's never today is the right time. That's all.
Right, right. And if you are in the session, please take a note. Today is the right time. Don't delay your visits to your fertility specialist. Obviously, down the line, you are really going to regret the decision of delaying your visits to the doctor. And we really want you to have success as early as possible. Dr. Shweta, thank you so much for joining today. Thank you, UNS, for this wonderful session. And we really love to have you with us for another session, ma'am. It's
Definitely,
nice
definitely,
talking to
Purnima. I enjoyed connecting with so many, viewers, and it was a wonderful sessions. Your questions were great. They were, I'm sure, it has cleared lots of myths around IVF. They were very common and very good questions. I think you have put it across for me. Thank you
you.
so much,
Thank you, ma'am.
Purnima. Okay,
Thank you. Thank
bye,
you for joining.
bye.
Bye bye.